Welcome to EMA, HMA Pilot Educational Program Oncology. This is the 10th and final webinar of our second oncology-specific part, and this will conclude our educational program. I am Harold Ensman
And I am Sabine Meyerhofer, and together we will guide you through today's webinar on biomarkers and companion diagnostics in oncology. Formalities are important, therefore here is the usual disclaimer. So far, our webinars have focused on medicines and on the regulation of medicines. That means on innovative pharmacological treatments for cancer. Of course, we all know there can't be a useful treatment without a diagnosis.
many of you will know the gods placed diagnosis before therapy. This famous line, usually presumed to be from Volhard, is frequently quoted. Many of those who use this line admit that they do not really know the exact wording or the proper reference. Well, here it is. The full wording here in the title of this 1952 brochure, and you will find an even more condensed wording, Diagnosis Before Therapy, inside this collection of his teachings. The precise diagnosis is a prerequisite for precision medicine. For this precision medicine that brought us so much closer to a successful treatment of cancer, sometimes even to a cure of cancer. At the end of the last millennium, at the beginning of the new millennium, two breakthrough medicines ushered in precision therapy of cancer.
The concept of targeting cell signaling, in the wider sense modifying the growth and survival of cancer cells by targeting the signal chain that drive their malignant growth, this concept developed over a long time. As early as in the 19th century, it was recognized that hormones drive the growth of some cancers, and surgical interventions were used to switch off the tumor's hormonal stimulation. The first pharmacological anti-hormone therapy, tamoxifen, was introduced approximately 50 years ago. And finally, imatinib, Gleevec, became the game-changer for the treatment of CML and was soon followed by many other tyrosine kinase or protein kinase inhibitors. About the same time, immunotherapy finally worked. First with monoclonal antibodies against cell surface proteins on hematological neoplasms, then with checkpoint inhibitors. These precision medicines, however, depend on precision diagnosis. They frequently depend on in vitro diagnostics for a precise molecular diagnosis, to a far bigger extent than the old medicines ever did. The clinical diagnosis by the treating physician, or the pathologist's histology, will no longer be sufficient. Very specific in vitro tests are needed to determine whether an individual patient can or cannot be treated with a specific medicine.
Allow us an analogy and an illustration. The old chemotherapy was a big gun, used against empirically selected tumors, neither precise nor accurate, and therefore causing massive collateral damage in non-cancerous cells. The new precision medicines target much better defined molecular structures, are meant to be more precise, are supposed to hit only the cancer, with normal cells and tissue expected to be spared. Of course, this can work only if the cancer we want to treat has these targets. This means we need to know if the molecular target is there in an individual cancer patient. And for this molecular precision diagnosis, we need the in vitro diagnostic tests, the companion diagnostic tests, which improve precision of the medicine, the accuracy of the pharmacological treatment, in a similar way as a scope improves the accuracy and precision in a shooting competition.
Enough of this analogy. Let's see now what the correct legal definition of a companion diagnostic is. On this slide, you have the wording of the European legislation. The companion diagnostic is essential for the safe and effective use of the medicinal product, and it is used to identify patients for the treatment. We may use the companion diagnostic to identify the patients for whom this medicine will work, because their tumor expresses the molecular target of the medicine we want to use. Or we may use a companion diagnostic to identify the patients who should not receive this medicine for various reasons. This may be because we cannot expect efficacy in these patients, or we have to expect particularly serious adverse effects, or because for some specific patients, this medicine may work, but there is a better therapeutic option available in their case. The example in this slide illustrates the complexity. For this medicine for the treatment of non-small cell lung cancer, the indication depends on as many as 4 different in vitro tests. The indication is limited to patients whose tumor has a high PD-L1 expression and does not have another driver mutation, which would make another targeted therapy first choice. At variants, the same medicine can be used for the treatment of skin cancer without the need of any companion diagnostic. How often a targeted medicine will have one or more companion diagnostics in its indication illustrated in the next slide.
This slide is from our CAM talk, our overview of centrally authorized medicines for the treatment of cancer, showing medicines that act on or modulate cell signaling. And now all medicines with at least one indication that requires the use of a companion diagnostic for the demonstration of the molecular target of the INRAD. And while most CDX are meant to detect the molecular target that drives the tumor, are meant to show if the cancer is vulnerable to a specific medicine or a specific mode of action, there are so-called negative biomarkers too. These are meant to identify changes that are prohibitive for the use of a specific medicine. In the example that we saw a few slides previously, the presence of other driver mutations would show that Libtayo is not indicated, as another first-line therapy, a therapy targeting these driver mutations, is better for these patients. For the immunotherapy of cancer, we have a similar situation, not for the old, somewhat unspecific immunomodulators, but all the new products, the checkpoint inhibitors and the products targeting surface antigens of solid tumors, they have at least one indication that depends on a companion diagnostic. Interestingly, this is different for medicines that target cell surface antigens on hematological neoplasia. The very precise diagnostic of the numerous different malignancies, for example of the lymphocyte lineage, seems sufficiently predictive for the expression of cell surface antigens, even without the immunohistochemical confirmation. This is why in these cases the confirmation of the expression of the target antigen for a monoclonal antibody is usually not required. But we will come back to this particularity at the end of this webinar when we look at examples. And yes, for the sake of completeness, for cancer immunotherapy there are so-called negative biomarkers too, meant to identify changes that are prohibitive for a use of a specific medicine. We expect that biomarkers or companion diagnostics will gain further importance, even exceeding their, as the regulation says, essential role. In the new tumor agnostic or tissue agnostic indications, the biomarker really dominates the indication. You see the increasing openness for such a new way to describe indications. Until recently, the agnostic indications were clearly last line. However, the latest wording is more open, allowing the histology agnostic approach when other treatment options may be available but offer limited clinical benefit. We need to see that these agnostic indications may introduce or create new disease entities, possibly sometimes replacing what we have currently in pharmacology textbooks. Today, we will have a chapter on the treatment of breast cancer and another chapter on the treatment of colorectal cancer. Might it be that the histology-based disease entities will be made obsolete? Will we have just a chapter on the treatment of ORAC-positive solid tumors, never mind the histology?
The companion diagnostics are, as the legislation says, essential for the safe and effective use of our medicines. This is why we need to assess the companion diagnostics together with the medicines, with the medicinal products, as they are linked and both together determined the benefits and the risks for the patients. Unlike the USA, where the FDA assesses both companion diagnostic and medicinal product, responsibilities in Europe are split. Medicine products are the responsibility of EMA, and the companion diagnostics, as in vitro diagnostic tests, are the responsibility of the notified bodies. Companion diagnostic are frequently developed in parallel with the clinical development of the medicinal product, as shown here. While the notified bodies will certify the companion diagnostic, it is unavoidable that the selection of patients in the pivotal studies, and therefore the rationale and the performance of the companion diagnostic, will be part of the assessment of the efficacy and safety of the medicinal product. Our knowledge and assessment is then shared with the notified bodies as foreseen in the legislation in the context of this consultation procedure. Nevertheless, the split responsibility remains. In Europe, we do not have FDA's one-stop shop. Rather, you have to go to different stores for the rifle and for the scope, even if you want to use them combined. In the context of the assessment of an initial marketing authorization application for a medicine with a companion diagnostic, it is by now the required standard to look at the scientific rationale, at the analytical and clinical validity, and at the justification of the cutoff, if applicable. EMA is transparent and predictable. What is assessed is exactly described in the templates for the assessment report, which are publicly available. So, to use again the analogy, in the assessment of an initial marketing authorization, we will not only assess the overall performance of the rifle with its scope, our assessment will also describe the quality of the scope which was used. However, this may become more complicated after the initial authorization of the innovative medicine.
At variance with the medicinal product, there is no data protection for the companion diagnostic. This means competing companion diagnostics may become available very early after marketing of the innovative medicinal product. This means you are free to use a different scope with your new rifle. But of course, if you replace a good scope with an inferior one, the accuracy of your rifle will decrease. Or, to use the words of FDA, if the diagnostic test is inaccurate, then the treatment decision based on that test may not be optimal. Unlike the situation for the initial marketing authorization of the medical product, where we see the details of the companion diagnostic as part of the marketing authorization application and include it in our assessment, for these follow-on companion diagnostics, EMA's contribution is limited to the consultation and based on the previous assessment of the companion diagnostic by the notified body. Let us look at a few examples. Examples from initial marketing authorization applications when biomarkers are or are not used to make the indication more precise. And an example from a follow-on competitive diagnostic that illustrates the particular challenges in these cases and why this means patients and their treating physicians have quite some responsibility, have to make deliberate and hopefully informed decisions.
Here you have the first example. Opdualg is a fixed-dose combination of two checkpoint inhibitors, nivolumab and relatlimab. The pivotal study demonstrated that the combination of both was more efficient for the treatment of melanoma than nivolumab alone. So far, so good, and admittedly there is some logic in taking this for face value and granting a marketing authorization without requiring a companion diagnostic. Nevertheless, we wondered, maybe the PD-L1 expression is a relevant effect modifier? Looking at the data it became, we had to conclude, yes, it is. Obviously, the overall efficacy in this trial is driven by the patients with a PD-L1 expression less than 1%. At variance, the other patients, more than a third of the overall population, did apparently not benefit from the treatment.
After this simple and straightforward example, the next is more complicated. Glofitamab is an anti-CD20 T-cell engaging antibody for the treatment of relapsed or refractory diffuse large B-cell lymphoma. The question was, do we or do we not need to confirm the expression of CD20 before initiating a treatment with this antibody. After all patients would have received an anti-CD20 therapy previously. Loss of CD20 expression has been reported as a potential mechanism of persistence. And of course, it may seem biologically implausible why an antibody targeting CD20 should work in the absence of CD20. Of note, previous decisions seemed not to favor a restriction of the indication. Only the indication for the first and the second anti-CD20 antibody, which were authorized more than 20 years ago, were restricted to the demonstration of CD20 on the malignant cells. Later, it was apparently conceded that CD20 is expressed in all, or almost all cases, and therefore all comer indications were granted. For the product at hand, there were data from only 3 CD20 negative patients. None of these 3 patients seemed to benefit from the treatment. Nevertheless, trying to be consistent with previous decisions and acknowledging that data from as few as 3 patients would not justify a deviation from previous decisions, the indication was not restricted. However, we included a warning in the SMPC to make patients and their physicians aware of this uncertainty, and possibly to make one or the other interested in more details and to look it up in the European Public Assessment Report.
The last example illustrates the challenges and pitfalls with follow-on companion diagnostic, in particular if there are several potential reference products around which were introduced before we got a meaningful in vitro diagnostic regulation. Unlike the public assessment reports for the marketing authorization applications for medicinal products, EMA's input in the consultation procedure of the modified bodies is confidential. This is why I will not tell you the name of the in vitro diagnostic test that was assessed here as a follow-on companion diagnostic. The applicant tried to show concordance of their immunohistochemical assay with a previously certified immunohistochemical assay. The negative agreement was fine. Problematic was the positive agreement. The 95% confidence interval would have meant that in the worst case, as many as 37% of patients would not get an indicated, important cancer therapy. This was considered not acceptable, and this view of CHMP was communicated to the notified body in the frame of a consultation procedure. The notified body then forwarded this negative view to the applicant. In response to this, the applicant amended their submission by comparing the results of their immunohistochemical assay with the results of an established genetic test for the same biomarker. And now the difference was in the single-figure % range. Acceptable. No reason not to certify this companion diagnostic. No reason not to grant the CE mark.
But, of course, there still is a difference between the 2 immunochemical tests regarding the positive test results. In this case, we do not know which test is more accurate, whether or not we can expect the medicine to work in the patients who are positive in one but negative in the other test. So we end in the unfortunate situation that patients and physicians may have to make a choice between tests without sufficient information. At the moment, if you prefer to err on the side of having the treatment, you should use the test that gives more positive results. If you are more concerned about the adverse effects, if you prefer to err on the side of avoiding the treatment, you should use the other test. Take-home message. Which companion diagnostic you choose, the method used and the brand, may make the crucial difference whether or not you get a specific treatment. If you have a choice between different companion diagnostics, and for some biomarker, several competing tests are available in order to make a choice. To make an informed decision, you may want to have a close look at the positive and negative predictive values of each test. And this brings this EMA-HMA Oncology Pilot Educational Program finally to an end. We hope you found it interesting, maybe even enjoyed it.
For us, it has been a pleasure. And here on the last slide, you have all the speakers' coordinates. Thank you for watching, and goodbye.
And here is the bonus we did not include in the live webinar. We only presented that depending on the expression of PD-L1. Efficacy appears different. More precisely, the treatment with Opdualag registered trademark, which is a fixed dose combination of the checkpoint inhibitors nivolumab and relatlimab, was more beneficial in patients with low PD-L1 expression, which was why the indication was restricted to patients with a quite low PD-L1 expression. With relatlimab targeting LAG3, lymphocyte activation gene 3, and nivolumab targeting PD-1, the receptor for PD-L1, it may seem surprising that a lower PD-L1 expression would be associated with better efficacy. Even more so, as this is different from the experience with nivolumab in monotherapy or with other checkpoint inhibitors. What we more usually see is that PD-1 or PD-L1 targeted antibodies work better for patients whose tumors have a high PD-L1 expression. It seems we have here a somewhat unexpected ceiling effect. It is exactly for these patients who benefit most from nivolumab alone that the addition of another checkpoint inhibitor, relatlimab, provides no further benefit. Patients with a higher expression of PD-L1 have a better clinical course than patients with a higher expression of PD-L1 when treated with nivolumab alone. See the blue line for orientation. It looks like that in these patients. The nivolumab alone achieves everything that checkpoint inhibitors can achieve. At variance, in patients for whom the treatment with nivolumab seems to be less efficacious, leaving them with a worse clinical course, in these patients, the addition of another checkpoint inhibitor provides additional efficacy, provides additional benefit, and this is apparently in line with an earlier, similar observation for the combination of nivolumab and ipilimumab. If ipilimumab is added to nivolumab in the treatment of melanoma, efficacy is increased. However, similar to the nivolumab and relatlimab combination, this effect is obviously driven by the subgroup of patients with PD-L1 expression of less than 1%. In patients with a PD-L1 expression higher than 1%, the additional treatment with ipilimumab does not seem to have an additional benefit. Again, a kind of ceiling effect. When nivolumab is at its best in the treatment of tumors with high PD-L1 expression, adding another immune checkpoint inhibitor seems not to add benefit. Well, seems regulators may have a learning curve too. For the combination of nivolumab and ipilimumab, this ceiling effect was not yet understood, so only a warning that efficacy is uncertain in these patients was added to the indication. The next time, things seemed clearer by then, and the indication of Opdualag was restricted. So, what to conclude from this? When different targeted therapies are used in combination, in this case different immune checkpoint inhibitors, each molecular target, the biomarker for each of the combined targeted therapies, may turn out to be an effect modifier. To make things even more challenging, the effect modifier may work in an unexpected direction, possibly in the opposite direction than we expect, based on the experience with the same products in monotherapy. Knowing as much as possible on the biomarker status of patients will help in the development of the new medicine to define the appropriate indication for the medicine and in the clinical use of the medicine to make the right treatment decisions for the individual patients, based their biomarker pattern. And with this, we are really at the end.
Thank you for watching, and goodbye.